Welcome to A New Prescription, where we explore modern healthcare, cutting edge medical research and technology, and the complexities of healthcare politics. Join us as we provide insights and solutions to help you navigate the American healthcare system.
Hey, everybody, it's another episode of A New Prescription. This is Len Zwelling. I'm here with my son, Andrew, and this is a podcast I have wanted to do from the very beginning because it's a subject that I think is getting lost. At least the truth of it is getting lost, and we need to discuss this. Many politicians, including the President of the United States, use the word sex and gender interchangeably. These two words are not synonyms, and I think using them as synonyms is confusing the public about the differences between sex and gender. And this has now led to a tremendous amount of confusion and chaos when it comes to the politics surrounding regulation of discrimination from office to the athletic field. So in order to make some progress and get some clarity, I've been asked Neha Verdi to come and talk to us. She is an MD PhD candidate student at Washington University. Her research involves sex variation in neurodevelopment, but her passion is the care of improving healthcare for underserved populations. Neha, welcome to A New Prescription.
Thank you so much for having me.
Great. Let's just get right into it. What does science have to say about the difference between sex and gender?
Yeah, great question. Overall, what science says is that they are different. Sex is driven by biological factors, while gender is primarily a social construct and therefore can change based on the context in the area that you are in. And that's primarily the main difference. And when we really think about that, we want to make sure that when we're talking about sex, we're really making sure that it's backed in science and those scientific evidence, while gender might have more of that cultural nuance that happens when we're really dealing with different societies and people.
Does that mean when it comes to sex now, for the most part, there are two sexes determined by the chromosomes?
Yes, so sex in its true definition is a biological construct. And as a society, scientists have sort of separated us into two main sex categories, males and females. And those are the predominant sex categories that make up the most of our population. And those are defined by chromosomes XX in terms of females and XY in terms of males. But there are, of course, exceptions to those, while those are, though, in the minority.
That was the next question. What does it mean to be intersex? What does that mean, that
Mhm.
word?
Yeah, so intersex is actually an umbrella term that really accounts for variation in different sex traits or reproductive anatomy. And this can mean different things. In the medical field, when we typically talk about chromosomal groupings, that tends to be considered sex chromosomal aneuploidies, which just means you have a different combination of sex chromosomes. So instead of having the typical XX for females and XY for males, you might have something called a trisomy, so an extra one of those, or something called a monosomy where you only have one X. It's actually not possible to only have one Y. That's not viable. But we have these changes in sex chromosomes. And so while XX and XY is the typical, there are variations among that. And even beyond sex chromosomes, being intersex isn't just related to that. You can be intersex with just differences in internal anatomy, genitalia, and external anatomy, hormones, or even at the molecular level that just are not typically expected within that sex trait.
Is it sex that for the most part determines physical development and for that matter, mental development in the sexes as they mature, go through puberty and mature?
Yes, great question. So when we think about, since sex obviously has this biological component, including both chromosomes and hormones, including testosterone, progesterone, and estrogen, all of those greatly impact how the body forms. at the primary level, so what genitalia we have, but then also at the secondary sex characteristic level that happens during puberty. So when we start to develop things like body hair, when we start to develop other secondary sex associated organs, then those are things that are still driven by biological sex, correct?
Okay, let's hold on to that thought because I'm going to come back to that when we talk about athletics and what's going on in sports. Let's get to gender. How would you define it? How does it differ from sex? And are there just two genders?
Yeah, so gender, as I said, is a sociological and legal construct. And so that means it's really influenced by the cultural and societal norms of the place that a person is in. And that means it can also vary across societies. So while here in the United States and a lot of Western society, we typically think of, the main binary as women and men, there are other societies where additional genders are very much considered typical. And we might see this in native cultures like in what's called three spirit. Um, and so gender is different than when we think of, when we compare it to sex, because sex is based off of characteristics that will not be changing when we go from society to society or place to place. Now, gender in and of itself is comprised of two different things, both, the gender identity that someone feels like they identify as, and then also how they express that gender identity to other people.
Okay, let's go to both of those things. Can you get some examples of how sex and gender differ from one another?
Mhm.
Other cultures, fine, preferably here in the United States. How do we differ? Because we certainly, when the president of the United States says there are two genders, we know that's not right.
Mhm.
Legislation and his decision making is going to be based on that concept. We're going down the wrong road almost from the very beginning. So,
Correct.
how do we get down the right road when it comes to
Mhm.
gender?
Well, I think we need to really go back and identify what are we talking about when we are really thinking about gender. And, gender can mean a lot of different things. The way we choose to dress, the certain activities and the hobbies and things that we tend to align ourselves with, the sorts of things that we really, the personalities and the mass media and, the general like um, sense of who you are as a person, and so therefore that's something that, can change over time even. So as we evolve and we change and we learn more about societal factors, people's gender expressions can change. Now, that's not what happens in the majority of people. In the majority of people, our gender identity does tend to be fairly stable in childhood and then continue on throughout adulthood. But in some people, since it is a social construct, as they learn more about the social world around them, they can choose to change their gender, identify with another gender, identify not in this pure binary as male and as a man and woman, because again, these binaries are really constructed by what we've deemed to be under this man or woman category. Boys are, sort of thought to be more likely to like action movies and these dinosaurs and things like that because we've sort of described that as a society, right? And when girls do that, we say, oh, that's not congruent with sort of like the gender stereotypes. And that's not to say that if a girl likes playing with, action figures or dinosaurs, that she's not a girl. It's just more like, how does she identify? And so when that person thinks of themselves, do they think of themselves as a constellation of factors that make them think, oh, I feel like I actually identify as a boy because of all of these things that I like, how I view myself in society, the roles that I see myself playing? Or do I view myself as someone that follows more of these feminine roles that typically tend to get ascribed to girls and women? And some people might feel like they're in the middle. Some people might feel like some days they feel like they go more with one or the other. And that's why gender is very much a social construct. It's, not something that we can point to and say, this is your gender. Whereas biology is different. Now, we can't really point at one thing and say, this is your biology, right? But there's many different factors that sort of give us the truth of what a biological sex is. And that won't necessarily change over time. Like now that's not to say that hormones necessarily won't change and stuff like that, but the ground truth of what sex chromosomes you have, what sort of hormones were there during development, what sort of anatomy you have. Those are things that might change a little with age, but don't tend to change all encompassing in the way that gender does.
So, what is a transgender person? And is a transgender person early in life, or is that something that can develop later?
Yeah, great question. So when we think about individuals that are transgender, it's essentially that their assigned sex, which typically is assigned at birth, doesn't align with their gender identity or the way that they sort of view themselves in society. And this can be because of many different factors. And so being transgender is again a wide umbrella, but it's characterized by having something that's called gender dysphoria, or the distress of not of ex- feeling that your gender identity does not match what society has sort of assigned you to, and can cause a lot of distress to people as they grow up and they want to behave in certain ways but are expected to behave in other ways based off this assigned characteristic.
In the
um,
case of most transgender, is it something that expresses itself early in a person's life, or is that something that can come later? Because
it
we're hearing a lot about distress in
Mhm.
teenage years,
Yes,
and we'll
it's
get
actually something that we've seen as early as in children. Like I said, some like children sometimes are very aware of their gender identity as early as 3 years old. Now that's not to say that we would necessarily diagnose a 3-year-old with gender dysphoria, but you can start to see signs of how children, have their own identity that might not match up with the identity that they've been given. So it can start to appear very early on. You're right, though, that a lot of children and kids start to really express this discomfort more in the preteen to teen years as the effects of puberty accelerate the discomfort. The fact that now their bodies are changing in a way and they're more expected to align with these gender stereotypes, when before typically kids, especially since they don't have these secondary sex characteristics, they have less of that sort of stereotype that's put on them to act a certain way. And so then in adolescence, kids are more likely to be like, oh, I'm starting to develop some features now that I don't want and are making this distress even more apparent. And that's why we tend to see them come into clinics, into doctors' offices more often.
perfect. When they come into clinics, how does the doctor need to approach that patient vis-a-vis, is this something I need to treat? And if so, how? How is
Mhm.
that by the doctor that's presented with someone who says who thinks they're transgender, let's just say?
Yeah. So a lot of the times, of course, ideally the first person that might actually get this problem from this child or this comment might actually be a primary care physician or like a general practitioner. And so I think the first step is really validating what a child is feeling, even if we don't necessarily understand where it's coming from. We really want to evaluate where that feeling is coming from. Where is that discomfort coming from? Because we want to ensure that it's not from other areas. And that's where really take referring children out to the appropriate child psychiatrist, especially if they have expertise in transgender care, and in gender dysphoria, is really, really important because then they have the expertise to be able to piece this apart. It's really important to ask questions like, okay, where is this discomfort happening? When is it happening? When are you noticing it happening? Is it when you're doing certain things? Is it actually because of the way that other people are reacting to you? We want to make sure that it's, not something due to external pressure or bullying. Um, because of course, we don't want people to misconstrue internal just gender dysphoria and conflate it with external bullying or pressure that people might be facing. Although that can be difficult because kids who experience gender dysphoria are more likely to be bullied because of it. But experts in child psychiatry are able to piece those apart with really, really long, um, essentially long interviews with both the kid, parents, people in the child's life, including teachers, other sorts of mentors and figures in their life, and they're in sports or other sorts of things. So it's not just taken at face value, it's very much dissected, to really understand where the distress is coming from because we want to make sure that we're addressing the right thing. If it is something like bullying, we want to address the bullying, and we're not going to fix that with necessarily addressing gender dysphoria if the child doesn't really have that. And so
If
that's why
someone
an expert is
decides,
necessary.
yeah, if a doc and the parents, and most importantly, the teenager, come to the conclusion that there really may be transgender, what are the options open? And let's be frank, some of these options are being curtailed in certain states, including
Yes.
the one in which I'm sitting.
Yeah,
In
and the one in which I'm sitting as well here in Missouri.
Missouri, yeah, okay, so that really puts a limit. If the assessment has been that this is really a transgender kid at the age of 13, what can the doctor in Missouri or Texas do?
Right. Great question. So, ideally, what is best practice? And the American College of Pediatrics and Child Psychiatry, they all agree with this. Best practice is to really, especially if it's before puberty, at the beginning of puberty, a child experiencing gender dysphoria, is to halt puberty for that time period, in order for the child to prevent some of those secondary sex characteristics, some of which can be irreversible if not halted at the time of puberty. There are, of course, things that later on with hormonal therapies can be later on adjusted even past puberty, but many secondary sex characteristics are irreversible at the time of puberty, and they can cause a lot of distress. So what is mostly suggested is to put children on pubertal blockers that then can be taken off and puberty will continue from those points. Or once the child reaches an age where they've sort of been able to talk about this a bit more, develop a plan with the adults in their life, and maybe have reached their own point of adulthood and can really sort of describe what they want to do next with their transition. This is really just like a pause point. It's hitting pause to give more thought, more time for everyone to really decide what might be the best thing for a child. Now, the reason why so many states are sort of getting transgender care blocked is because of the misconception that there is irreversible harm being done to children who are or transgender at these clinics, and that is not true. Um, Pubertal blocking is temporary and it is safe, and it is not common for children to receive body altering or permanently like body altering changes in adolescence, even if they are transgender. And if that tends to happen, that tends to happen after many, many years of, pubertal blocking conversations with psychiatrists and with therapists of all different decisions. And the level of distress a child is feeling is just too great to continue to that level. And then maybe then they'll get to that point. But it is way less common than what the general media and politics will lead you to think.
So 13-year-olds are not being operated on?
No.
Yeah, I think that's one of the points I want to get through here today is that the banning of pubertal blocking is really a great disservice to these kids. And there is this notion that more destructive and interventional, irreversible kinds of things are going on when in fact they're not.
Correct.
Okay, I wanted to get to that. Okay, now the one that is really making headlines is the idea that men are in women sports. Now, my understanding is that if a biologic man does go through puberty and then decides that he is really a she, that person has a massive leg up on the rest of the female competition in any sport. And the example was the transgender woman who was competing for the University of Pennsylvania in swimming, who had been just a mediocre swimmer as a male and became an all-star when he became a she. I think that's a pretty unusual turn of events. You don't see that too often. But there are these occasions where where men have gone through puberty and then decide that they are women. That really is true. But the question I have for you, what is known about the hormonal status of world-class women athletes vis-a-vis things like testosterone? are they different than the average woman?
Right. Now, this is an exact question that I really encourage people to think about when we start, really thinking about things like transgender people in sports. So there is the concept, the sort of thought process that having gone through puberty, like I said, there are some secondary sex characteristics that you do go through that are irreversible. And that is true. But a lot of those are very hormonally mediated. And to maintain some of those secondary sex characteristics, you also need a steady supply of those hormones. And in key, I'm really talking about testosterone when we're talking about sports. Because when people are really talking about the effects on the body, especially for transgender women, it's the assumption that now increased things like muscle mass, bone mass, et cetera, have now conferred a biological advantage that now has, sort of made them um, be able to be advantaged in a different group. What's really interesting, though, is that scientific studies have actually shown that hormone replacement therapy, when transgender women are sort of going on estrogen replacement, they actually experience a loss of muscle mass and bone mass, making them actually quite comparable to maybe to the average to higher level of cisgender women. And so, of course, there's a typical range that all women sort of fall on, and you'd get to be in that range with hormonal therapy as a transgender woman. Now, to get to your question, because of that range, as you can imagine, cisgender women also can have high levels of testosterone naturally in their body. That happens. And what's actually been seen is a lot of really high powered cisgender athletes tend to have higher levels of this testosterone naturally, to the point where now there are actual testosterone tests at different professional sports levels, like the Olympics. And some of those have become controversial in and of themselves, as to like a certain level that even all cisgender and transgender, all people have to meet in that sort of group in order to sort of be in that same range. So it's interesting because this level of hormones, this question of hormones and its effect on the body is something that is talked about with both cisgender and transgender women, but in a separate context, which really I think is detrimental because it's really talking about the same thing, the effects of things like estrogen and testosterone on the body. And really, if that's what we're going to focus on, then transgender women do have that covered.
Okay,
So
so the chance, I mean, some places are excluding or including transgender women based on their testosterone
mhm,
levels, but they don't make that measurement on the cisgender women.
mhm,
When in fact,
they
it's
might have higher levels than the transgender women in that same group.
just look at the WNBA.
Mhm.
There is no chance that some of those women who are 6'6" and can dunk don't have some sort of biochemical advantage, even over the competitors on the court with them.
I mean, we have to think about what are sports fundamentally. Sports are really people at different peak physical fitness competing against each other, and everyone has a natural advantage or disadvantage to the person next to them. If you're a little bit taller than the person next to you, that's not something that they can compensate for, but they can compensate for in other ways. And so naturally, sports, we have that physical disadvantage, but we want to make sure that it's in a similar range so that we don't have someone that's really skewing everyone out of the park. And I think that's what people are worried about. But what's really interesting is the evidence shows that that's not the case. Transgender women, when they're put into sports, and transgender men, when they're put into men's sports, they tend to actually fall in the middle of the pack. They don't tend to really be winning everything. Of course, there are exceptions, like you said, but just like there are exceptions in anything, when we think of Katie Ledecky, she's dominating swimming, outswimming every one of her competitors. If she were a transgender woman, and honestly, some people are almost sort of making up the fact that she's a transgender woman because she's so absolutely like competitive at what she does, it's almost the fact that it's almost sort of like for a woman to be that good, they have to have something extra going on. And it's sort of that same idea with transgender woman. You're only sort of winning because of that one thing. And that's not really the case. And now on top of that, when you put on top of that the fact that this is such a huge conversation when there's 10 transgender women in all of the 500,000 women in NCAA sports. Now you add that on top of everything, and it's really ridiculous. We're making all of these rules and all of this fuss for 10 people who want to just be involved in sports and might naturally just fall in the middle of the pack anyways. And then you start to see things like, again, with the Olympics, we see cisgender women who are sort of by the public called transgender women because they are exhibiting what people call masculine traits. And again, this is why gender is so socially constructed. You look at someone and you think these traits are something that should be associated with a man or with a woman. And there are some sort of those traits that are associated with sex. Like, yes, height is associated with testosterone and sex, but it's the gendered view of it that is harming us here. If we were thinking about it from a sex perspective, a biological perspective, or sort of the way that we would actually make these cutoffs would be different, because we would be thinking more about the basic biology behind it. We wouldn't be thinking about what do you identify yourself as, because that's not the point. The point is, what is it in your biology that's giving you an advantage over someone else? And if we're talking about that, that has nothing to do with identity. And so that's the fundamental problem.
So let's get to the heart of the matter when it comes to politics. What is the role of the government in any of this? I mean, should they stay out, or, and it seems that there's a demand in the country, although it may have been very artificially drummed up, does the government have a role in certainly gender affirming care in young people, and in terms of the politics of athletic competition as well? What should the government, is there a good role for the government? Could they be constructive in all of this? Not what we've seen so far. Is there a constructive role for the government in this? And who else should be involved besides the government? That's for sure.
100%. So I think there is a role that the government can play and does play in ensuring that the right information is put out there and the right policies can be made. I think the most important thing is that scientists and medical professionals are the ones that are really leading these conversations, because at least on the biological sex side, and that we have people who really understand gender, sociologists and people who have studied this for a long time, be a part of those conversations together. We need people who understand sex and people who understand gender in the rooms driving these decisions, because those will be the people that can really be able to tell you, yeah, this bill that's saying based off of, for example, one of the executive orders that have sort of said there's two genders, male and female. That's even biologically inaccurate because it's based off of chromosome. And that in and of itself, if you had just asked a doctor or a scientist, they would have told you that bill is factually incorrect. And so it's really funny how even at the basic science level, it really is just the fact that right now we don't have trustworthy scientists that are there leading the helm. And I think that's really, really, really where we're sort of losing our integrity in our public health policy. And I think also what's really important is the government should be there to support what scientists and the people say are really important, to provide resources, to provide things like, to be able to provide the communication, to be able to implement some of the things that we suggest. I think that is really the key part of the government, getting experts together, providing them the means and resources to put together what they think are the best things for the public, and then being able to get the resources together to actually get those things implemented. That's what the government should really be able to do. But we don't want the government to be in the room with the patient and the doctor and we don't want the government there in that room. And I think that's really where we're going to, is that the government now is in every single patient, doctor's room, clinic room with us, telling us what we can and can't do, what a doctor can and can't do, without knowing any of what's actually happening to that person. And that's fundamentally the problem. We need to give medicine back to patients and physicians and take medicine back from the hands of the government.
Okay, well, I'm too old to do that, but you aren't. You are about to launch into your career as an MD PhD, so you'll be doing investigation as well as patient care as part of your life. How are you, just on a personal level, how are you going to, I mean, you're working in the neurosciences. You're actually trying to get to the biologic basis of sex and gender in the brain, So how are you going to pursue that at a
Mhm.
level? That's important. And then how are you going to be an activist for getting the government in the right place and off your back to some extent?
Yeah.
What's your plan?
Great questions. So I think what's really great about being in this physician scientist role is exactly like you said, I'm able to sort of learn a bit about the both. I'm getting my PhD in neuroscience on the basic molecular differences between girls and boys as they, develop both in utero and after birth. So I can really get a sense of where are these starting from. And that's really to help inform the public, sex differences are something that impact us all the way from the very start of at the very start in utero and conception, they continue. So I want to be very clear that sex differences are important in medicine, and that's a separate point. But what I'm doing sort of on the clinical and public health side is working with the American Medical Women's Association. We have a sex and gender health collaborative that has a very fundamental advocacy part of it. So we work with organizations like the AAMC, things like their LCME requirements. We work with the licensing exams for, medical students and other health professionals to try to get sort of this information in at the health sciences level fundamentally first. What's really interesting is, we're talking a lot about the conflation of sex and gender. That happens in the biomedical field all the time still, because it is really complicated when we think about healthcare. How can we really disentangle sometimes those things? And so they are conflated. So that's an inherent problem. But more than anything, I think it really boils down to science communication with the public. How are we really able to communicate with the everyday person? And the way that I'm really trying to do that, and especially with the Sex and Gender Health Collaborative, is we're working on a series of educational resources that are really to help the everyday person fundamentally understand what is sex, what is gender, and what does that mean and when it pertains to your health. What does that mean and pertains to your cardiac health, to your brain health, to the way that are in sports? For example, like women are 5 times more likely to get an ACL tear, like things like that. Because I think showing people why sex and gender are important and how they're different will help clear up some of this confusion. And so I'm doing it from the science communication standpoint. I have many colleagues that are also doing it from a more community-based standpoint with, people who are transgender and who have differences in sexual differentiation. How do we get that sort of information about their experiences out there so that people can understand, where they're coming from? That also is a whole different avenue that people can take as well.
That's a good way we can get to the end, I think, is if people want to learn more about what you do, about the resources you just talked about, how can they find out about it? Are there specific websites that people can go to? And what are they?
Yeah, so I recommend the American Medical Women's Association. It's AMWA dash doc.org /SGHC. So that's AMWA dash doc.org /SGHC. And that will have all the sex and gender health resources available and also information about me and other people that are on the collaborative, which mostly is comprised of physicians who have been doing this work for the past 30, 40 years. So people who have been researching sex and gender for a really long time. And I think seeing through their eyes how the recent administration has sort of changed things, it's interesting because as we know, history comes in cycles. It wasn't very surprising to them because they've sort of been through this before, but it sort of shows the need for the continuation to really reinforce why these are different and how the fight keeps going even 30 years later.
It's about now that I asked Andrew if he has any questions, since he's a layperson and you and I supposedly aren't. What do you think, Andrew?
No, my question is when someone walks into a doctor's office, should they be looked at as their sex
Mhm.
or gender? Because I think that matters when it comes to patient outcomes.
Yeah, thank you. That's a great question. So I think it's really important that I'm gonna be a little annoying and I'm gonna say I think both of those things are very important. I think the first fundamental thing though is sex, biological sex, because that I think has a really key role when it comes to disease process, prevalence, things like that. And when you're talking to a clinician, that's going to be something that's really important to them. Now, what we're starting to go towards in clinical offices is trying to get more specific with what we mean by that. So in a form, you might see sex, you might see gender. So we're trying to get those things separated. But in actuality, most of the times when you're walking in the clinic's office, they're going to ask you, they're going to sort of take you for what they're socialized to see you as, first and foremost, is how they sort of see you, which is can be a detriment because if you're not like sort of like in the sort of viewpoint as someone be socialized to see you as, that can be difficult, which is why we have those forms. But I think actually the problem is those forms aren't really getting us to the right information. I think in order for us to get to the right information in a doctor's office, we should be asking, yes, of course, what's your sex assigned at birth, but I really want to know, like, what organs do you have? Like, do you have a uterus? Do you have testes? Because sometimes even asking the sex question doesn't even get you quite there yet. Anyway, so this is my way of saying sex is very important. Gender is important when it comes to those social components. But sex is probably going to be the main thing that a clinician will be most interested in when you walk into their office. Although that isn't necessarily the way patients are asked that.
Okay.
That was a good one, Andrew. Very good. Excellent. Well,
Yeah.
thank you so much for your time and
Yes, of
very,
course.
very informative.
Mhm.
This is exactly what I had hoped we would discuss because I think in the lay press, it's being bandied around improperly and imprecisely.
Right.
And your point about what science has to say and how important that will be in governing legislation and the implementation of legislation is really critical. So that's great.
Thank you so much for joining A New Prescription. We're so excited that you stopped by. Please join us on our social pages at A New Prescription and also subscribe to our YouTube channel at A New Prescription YouTube. Remember, your health is the most important thing to you. We'll see you next time.